So thank you for joining us. We will begin the presentation. We appreciate you being here. Welcome everyone. Thank you for joining us for this webinar focused on Alport syndrome and the eyes, what patients should know. The session is 60 minutes with approximately 30 minutes of presentation, followed by 30 minutes of Q&A. Live closed captioning is available by clicking the CC button at the bottom of your screen. We ask that you please refrain from using the chat function during this webinar to avoid any distractions from messaging. Please hold your questions until the presentation is complete, and then we will definitely encourage you to use the Q&A function at the bottom of your screen to ask questions. I'm Lisa Bonebrake. I'm an Alport patient, parent of a patient, and executive director of Alport Syndrome Foundation. For those of you who are new to us, Alport Syndrome Foundation is the leading independent nonprofit organization in the United States, educating and giving a voice to the Alport syndrome community of patients and families. Our mission is to improve the lives of those affected by Alport syndrome through education, empowerment, advocacy, and directly investing in research. I'm honored today to introduce you to today's expert speakers who are generously volunteering their time to educate us about the understudied and underrepresented topic of ocular challenges, eye challenges documented as aspects of Alport syndrome. After their presentation, my colleague and fellow Alport patient, Kevin Schnurr, will moderate the discussion. Kevin is ASF's Director of Communications and Patient Engagement, and also a patient. Dr. Paul Bernstein is a professor of ophthalmology and visual sciences at the School of Medicine at University of Utah. He earned his undergraduate degree, PhD, and MD from Harvard University, did his postdoc and residency at UCLA's Jules Stein Institute, a fellowship at Massachusetts Eye and Ear Infirmary in Boston, and joined the University of Utah and the faculty of the John A. Moran Eye Center there at University of Utah in 1995. Dr. Laith Al-Rabadi is assistant professor of nephrology at the University of Utah. He finished his undergraduate medical training at Jordan University of Science and Technology in 2007. He then joined the Edelman Lab at Harvard MIT Division in Health Sciences and Technology. Dr. Al-Rabadi finished his internal medicine training at University of Iowa in 2013, then moved on to nephrology training at Boston University Medical Center. His clinical interests include glomerular diseases, transplant, and peritoneal dialysis. Dr. Al-Rabadi established a collaboration with Dr. Bernstein from Moran Eye Center to perform clinical studies related to Alport syndrome. He treats many Alport patients and is committed to advancing the field of glomerular diseases and Alport syndrome at the University of Utah. In 2020, Dr. Al-Rabadi joined Alport Syndrome Foundation's Medical Advisory Committee. We're grateful and honored to have him, as we are his one of his mentors, Dr. Martin Gregory, also at the University of Utah. We're grateful for Dr. Gregory's long-term commitment to Alport syndrome as well. And before I turn it over to Dr. Al-Rabadi, I just need to say, go Utes. My eldest son happens to attend the University of Utah, which I'm very proud of. I'm excited now to turn things over to share screen with Dr. Al-Rabadi, who will begin the presentation. We'll move then to Dr. Bernstein. After the presentation, Kevin will begin moderating. Thank you so much for joining us.
Can you see my screen, Lisa?
Yes, we can. Thank you, Dr. Al-Rabadi.
Perfect. Lisa, Kevin, thanks a lot for all your help and work in coordinating this. You did a great job. Thank you so much. So my name is Laith Al-Rabadi. I'm a nephrologist at University of Utah Health. It's a privilege to be here today. It's a privilege and a great opportunity to talk to the Alport community. I always say this field would not have advanced without the dedication and the support of the Alport patients, specifically, and special thanks to them, mothers and the wives of Alport patients who push this field forward. Thank you so much. Okay, so we work in close collaboration with the Moran Eye Center and Dr. Bernstein team. This collaboration between the Moran Eye Center and the Renal Division at University of Utah was established initially by Dr. Bernstein and Dr. Martin Gregory more than 10 years ago and led to significant advances, mostly in diagnosing Alport syndrome by assessing the thickness of the retina using ocular coherence tomography, which we're going to be talking about in more details later. We provide care to more than 160 families with Alport syndrome. We have also conducted several studies, mostly focusing on diagnosing Alport syndrome using an ophthalmologic approach and ocular finding. I'm a clinician, so I'm going to start with a clinical case to demonstrate the flow and how we streamline the process and how do our patients get referred to Dr. Bernstein and his team. So 20-year-old male patient presented with a kidney clinic after a routine urine test, showed the blood in the urine. Further questioning did show that the patient has a strong family history of blood in the urine. So what are my options as a clinician here? One option to consider is to perform a kidney biopsy. You may know that a kidney biopsy may not be conclusive, and early during the course of the disease, there may not be typical findings of Alport syndrome, and diagnosis may be missed. One may suggest doing a genetic testing, but again, until recently, genetic testing was so expensive, not always available, and sometimes with more than 500 Alport mutations, a mutation can easily be missed, and you may miss a diagnosis or a second mutation in the case of autosomal recessive Alport, and diagnosis just be missed just by the limited technology we have. As a clinician, I will be desperate for any additional piece of information. Hence, our approach using an ophthalmologic assessment to look for any finding that can help me diagnose Alport syndrome. Let's give a quick overview about the genetic background of Alport syndrome. Patients who have Alport syndrome have a mutation in alpha 3, 4, or 5, which compose collagen 4. Collagen 4 is the backbone of the basement membrane in the eye, ear, and the kidney. And if you're wondering why would a patient with Alport syndrome have hearing problem, kidney problem, and eye findings, it's just because they have a very similar structure of the basement membrane and collagen 4. And here I'm going to show you an example about how does the normal basement membrane look. Look how homogeneous and consistent it is. Whenever you have a mutation, whenever you have Alport syndrome, and you have some kidney abnormality, you have irregular thickening and thinning of the basement membrane. It's not homogeneous anymore. This is what we call actually a basket woven appearance of the basement membrane. You can tell from the name, basement membrane is a membrane to which the primary cells are anchored. So if you have a problem with the basement membrane, you have a problem in the kidney, ear, and the eye. And since our focus here is the eye, we need to know where the collagen 4 is present in the eye. It's present in the retina, cornea, and the lens. And the eye findings or the eye symptoms will be related to a defect in one of those parts. So again, the most common form of Alport syndrome is the X-linked Alport, in which one does inherit the mutation from the mother. X-linked Alport syndrome accounts for 85% of the cases. And similar to kidneys and hearing issues, males tend to have more severe symptoms compared to females. And they tend to have findings like lentoconus, which we're going to be talking about. Dr. Bernstein is going to talk in more details about this. And the presentation or the ocular findings may vary according to the genetic background. If a patient has autosomal recessive Alport, he needs 2 mutations to develop autosomal recessive Alport. One mutation coming from the mother, one from the father. And the least common form is a spectrum. The mild form is a thin basement membrane, and the most extreme end is autosomal dominant Alport. They tend to have kidney disease, but they don't tend to have eye issues or hearing problems. Some important facts to emphasize in Alport patients. Most Alport patients don't have vision problems. So as I mentioned, one of the things I do is to refer my patients to Dr. Bernstein and his team. And the first thing the patient may say, doctor, I don't have any vision problems. My eyesight is completely normal. Definitely, most patients have very subtle eye findings that can be very helpful from a diagnostic standpoint. And if they have significant abnormalities causing vision issues, those are mostly treatable. Hence our approach of referring those patients and emphasizing the importance of doing at least or starting with one ophthalmologic exam. Similar to hearing issues and kidney problems, males with X-linked Alport tend to have a more severe form. However, in the autosomal recessive Alport, women and males tend to have about the same severity of the disease. How about children? Eye abnormalities are less common in children. So whenever we refer a child to Dr. Bernstein and his team to evaluate, it's good to start with a baseline exam. However, we don't expect to see a lot of ocular finding. And actually what we would recommend is to do an eye exam in the matter to assess for the retinal thickness and other ocular findings. Because even though she may not have any kidney problems other than the blood in the urine, she may not have significant hearing issues, she may still have some subtle eye findings that can be very helpful from a diagnostic standpoint. Symptoms that patients present with are related to which part of the eyes is mostly affected. Patients may complain of gritty dry eyes related to recurrent corneal erosions, which tend to be more common in Alport patients compared to the normal population. Patients may complain of difficulty focusing and the need to change the glasses all the time. This should trigger concern about anterior lentoconus. It's common up to 30% in male with Alport syndrome. If you see a female with anterior lentoconus, one should think about the other form of Alport syndrome, which is the autosomal recessive Alport syndrome. Females with X-linked Alport syndrome don't tend to have anterior lentoconus. If the retina is involved, you may just have those whitish, yellowish infiltrate. They don't cause any vision issues, but they're very helpful from a diagnostic standpoint. However, in rare situations, the patient may come and complain that he cannot read a book, but he can see the corners just fine. In this case, you have to be concerned about giant macular hole. It's a giant macular hole. This is very rare, but should always be considered. I'm going to talk about just two ocular findings. The first one is anterior lentoconus. One of the reasons I want to talk about it because it's common in males with extended Alport syndrome and females and males with autosomal recessive Alport syndrome. As I mentioned, the main common symptom is difficulty focusing and the need to change the eyeglasses. When we do an ophthalmoscopic exam or a slit lamp exam, you see a typical red reflex on the exam. We care about as nephrologists because it does correlate with early renal failure and early hearing loss. It can be mistaken for a cataract and can actually predispose to cataract. But the good thing about it, once it's treated, it does not recur. Peripheral retinopathy, which is the flecks we mentioned, those whitish, yellowish exudate you see here, right? They're very helpful from diagnostic standpoint, and they're very common even in females who only have blood in the urine with no protein in the urine, no kidney disease, no hearing issues. So it can be very helpful from diagnostic standpoint. The one I want to focus mostly on, and the one that has been crucial and central to our research, is ocular coherence tomography. Ocular coherence tomography is a non-invasive imaging, which I like to think of as the ultrasound of the eye. But instead of using ultrasound waves, we use the light. And you end up with a cross-section image like that. And each layer here represents one layer of the retina. This is the macula. So this is the optic disc from which the vessels originate. And just to the outside part, in the opposite direction from the nose, this is the macula, which is an pigmented oval-shaped area. It's responsible for the central high-resolution vision. And in order to do some mathematics, we would like to divide it into inner circle and outer circle. So inner circle and outer circle. Those regions closer to the nose, we call them nasal 1 and nasal 2. And the outside, the other direction, temporal 1 and temporal 2. So let's take a look at the image here and compare it to the normal patients. So we look, this is the outside, this is the temporal part, and this is the nasal part. One would expect that in Alport patient, the thickness of the retina here is much less than the thickness here. So the difference, if you do the mathematical calculation, you would expect the difference to be much higher in Alport patients compared to normal. And we use this trait or this characteristic to diagnose Alport patient. So as a kidney doctor, things we do a simple ophthalmologic exam, we order for some retinal photographs, we order ocular coherence tomography, and we refer to an ophthalmologist. And here I would like to hand it over to Dr. Bernstein.
Okay, Leith, okay, have you released the screen? Okay, now it's my turn. All right, I assume everyone can see what I'm showing here. And I'd like to thank Dr. Al-Rabadi and for the organizers of this to allow me to give a talk now about Alport syndrome and how it can affect the eyes. Dr. Al-Rabadi has given a good background. There will be a few things that will be repeats in my talk, but they are very, very important points. So I think they deserve being said multiple times today. And I also want to give a very, let me just fix this for a second here. Laser pointer. I also want to give definite acknowledgement to my fellow, Dr. Nico Ronquillo, who prepared this talk for me. It's been a very busy time for me in the last few days, and he graciously volunteered to put together this talk today. And he's interested also in inherited retina disease and has really learned a lot about Alport just by putting this talk together. So as usual, we need to just disclose I have no financial disclosures, and I'm very happy to be working on this project. I have gotten to know the kidney doctors very well at the University of Utah through a very long number of years. Dr. Martin Gregory is the first one that I worked with, and he taught me so much more about Alports. I can say that we as ophthalmologists are not as educated as we should be about Alport syndrome, and it's been wonderful collaboration, and I'm very glad that I and my colleagues have been able to contribute to some important advances on eye care for and diagnosis for people with Alport syndrome. So we'll start with just a little bit of history. Alport syndrome has been known for almost 100 years. Dr. A. Cecil Alport in 1927 had the first report of several family members with nephritis and deafness. But very interestingly, eye problems were not noted at this first publication. So this is a recurring theme, as we will see through the years, that eye problems have been not brought to the forefront, but we are encouraging the take-home message from all of this talk today is that the eyes are important, and especially if you are diagnosed with Alport syndrome or suspected to be carrying the gene or at risk for developing Alport syndrome, it is important to periodically get eye examinations because there are things that we ophthalmologists can help with and make you have a better visual life. So Dr. Al-Rabadi has talked about several eye abnormalities, and these are the ones that we will be talking about in my talk today. We'll talk a little bit about the front of the eye, the cornea, some various corneal problems, including recurrent corneal erosions and posterior polymorphous corneal dystrophy. We will then move to lens. He's already mentioned some about lenticonus and cataract, and I'll talk a little bit more about that. And then my specialty is retina, and we will talk about macular holes, which are not all that common, but can be a significant form of vision loss, and about diagnostics of using OCT to help in the diagnosis of Alport syndrome, even if the changes we are seeing are not truly visually significant in most cases. So when should you see an ophthalmologist? Well, when anyone if you're newly diagnosed with Alport syndrome, we strongly encourage you to be seen, to be examined, to look for lens changes, to look for, to have a baseline OCT, to document if there is any thinning of the retina. It's a very wise thing. We can also pick up other problems that may not be related to Alport syndrome, glaucoma, other things that may be important so that you can have good vision for much of your life. We also recommend if you have a strong family history of Alport syndrome. As we can see with OCT, it can be used for screening and picking up in a non-invasive way whether there should be suspicion that Alport syndrome may be manifesting in the future. And then, of course, if you have any visual symptoms, you should always see an ophthalmologist. There's many things that we can help with. So when we do an eye examination, we first do measure visual acuity on the eye chart. We will check patients for glasses and making sure that we can maximize the vision if necessary using glasses. And then the very common way that we examine the patient is using something called a slit lamp. And that's shown here in this slide, where the doctor looks through a microscope and sees a very magnified view of initially of the outside of the eye, looking at the cornea, the lens, and the iris. This is usually done after we dilate the eyes so that we can get a good view of the retina. And then using special lenses, we can also look at the back of the eye and look at the retina. Also, and that's shown here, not only do we use some small lenses called a 90 diopter lens at the slit lamp, but we have another device that we wear on our head. This is called an indirect ophthalmoscope. We hold a special lens in front of the eye, and we can get a much larger field of view of the back of the eye that's also in 3 dimensions that allows us to see out to the far edges of the retina. This is the only discomfort that we are usually causing to patients is our lights are bright. We readily acknowledge that, but we need to see to the back of the eye. And once, we are using safe levels of light that we're delivering to the eye. But you may feel a little bleached out afterwards, kind of like having a flash camera directed towards your vision, but that will wear off. So starting from the front of the eye to the back of the eye, what kind of symptoms can Alport syndrome cause, and what would cause patients to be coming in? Well, you may have eye pain. People complain of discomfort, or you may have blurry vision. Those are the main things that can be caused by front of the eye problems in Alport syndrome. This shows what we see when we look through a slit lamp. You can see a normal clear cornea, where we can see the structures of the iris here. We can see the pupil, and then we can see the conjunctiva, which is the blood vessel covering over the white part of the eye. This is a perfectly normal eye examination. In certain situations, and in particular in Alport syndrome, there can be changes in the cornea, often at the back of the cornea, little deposits and opacities, and you can see them outlined here. And if you have enough of these, this can cause blurring of vision. And also, sometimes these are on the front of the eye, on the epithelium. And if there are problems at the front of the eye, you can have recurrent corneal erosions. There's a layer of cells on the surface of the cornea. And if they have poor adhesion, which sometimes can happen due to the collagen problems of Alport syndrome, this can cause pain, blurry vision, light sensitivity, and tearing if you have a break on the surface of the eye. This can be treated very quickly with lubrication using artificial tears. We might put a placement of a bandage contact lens, which not only will make things better in terms of symptoms, but we would also, especially if there's a break in the surface here, we would then also start a person on topical antibiotics to make sure that there's no infection. In very severe cases, if this keeps happening, there are various surgeries that we can do to try to create better adhesion so that these recurrent corneal erosions do not happen. Fortunately, I would say in my experience, this is not a common finding in patients with Alport syndrome. Another thing that can happen is these white dots in the cornea. This is a condition known as posterior polymorphous corneal dystrophy. This usually does not cause vision problems, but in very severe cases, if this starts to opacify the back of the cornea, this could require a cornea transplant. Again, fortunately, this is not something that we commonly see in Alport syndrome. Other signs other things that can cause blurry vision that are probably a little more common are the cataracts or lens changes, either cataracts or these lenticonus, which means that these are the dimples here that occur in either the front or the back of the lens. And you can see the little dimples right here. These, in In mild cases, this can be corrected with glasses, but in severe cases, this could require cataract surgery. In cataract surgery, we make an incision in the front of the first in the eye at the limbus where the cornea abuts to the sclera, and then make an incision into the lens, and essentially using ultrasound take out the interior material of the lens and remove all of that, and then place in a new clear intraocular lens made of plastic, an acrylic plastic. This is very, very common surgery. Several million of cataract surgeries are done every year, mostly for age-related cataract. But so do not be afraid. Cataract surgery will work very well if you start developing lens problems that cannot be corrected with glasses or contact lenses. So other reasons beyond blurriness is that you could have other findings that you just can't see very well. Patients come in, and that can be often are due to problems that are related to the retina, the thin film at the back of the eye. This is a picture of a normal retina. This is the kind of view that we get when we're using an indirect ophthalmoscope. You can see the optic nerve here. You can see the blood vessels that emanate from here. There are arteries that are the smaller vessels that are coming out, and the veins are where the blood returns. Right here in the center is the macula. This is the area that's most important for the vision that most of us value the most in our daily life. This is this is where the photoreceptors are present for reading, driving, recognizing faces. Even though it occupies less than 4% of the back of the eye, it is responsible for the vision that we need for central vision. The other 90-some% we use for dim light vision and for our peripheral vision. That is every bit as important and can be lost in certain conditions such as retinitis pigmentosa. But fortunately in Alport syndrome, there's usually very few functional problems with the peripheral retina. And we will also get, as part of an eye examination, we get this optical coherence tomography. Dr. Al-Rabadi discussed how that is like doing an optical ultrasound of the back of the eye. And shown here is a cut that would be right through, a horizontal cut right through the macula. And at the macula, there is a thinning here. A very smooth dip right in the center of our vision. This is the area that's most important for our central vision. And this dip is what we use to find where the center is. We know that we're taking a picture right in the center of the retina. And then you can see the various layers of the retina here. And we are looking for abnormalities in these areas when we're doing OCT. And we're also measuring the thickness of the retina. One example of a problem that does occur in Alport patients is that you can have such thinning of the retina that it opens up a hole. So literally the retina, there is no retina here as I'm outlining. You're looking at the next layer of tissues, which is the retinal pigment epithelium shown in orange right here. This is a macular hole here, and shown on an OCT, you can see this gap right here. Macular holes, when this happens, the vision of this patient would be very poor, probably about 2400. They would just be seeing the large E on the eye chart. This is, Alport patients get what are called giant macular holes. This is much larger than a macular hole that we would normally see in a patient. A normal a common garden variety macular hole would be the size of my laser pointer, just shown right here. So unfortunately, should an Alport patient develop one of these giant macular holes, these are very, very hard to close and very hard to treat. So we need to get better at treating these. Common macular holes, we have a 90% success rate in closing those and improving the vision. But the collagen changes are definitely make these much more challenging to treat. I got involved in this project in working on Alport syndrome when I was approached by Dr. Martin Gregory. And there had already been some evidence that there were changes that we were seeing when optical coherence tomography became became available, that people in Australia and here in the United States were noticing that there were changes of macular thinning seen on optical coherence tomography. And shown here as a very similar picture to what Dr. Al-Rabadi showed, in that this is a normal eye, and you can see the retina is a little bit thicker here on the nasal side, closer to the optic nerve, and is a little bit thinner here, but we know this is normal. This is what we would expect. But when we were seeing Alport syndrome patients, we would see that the thickness was mostly normal here, but it was especially thin on this side. So using a grid called an ETDRS grid and measurements, we took the numbers that were found in these various regions called temporal 1, temporal 2, nasal 1, and nasal 2, and we developed a formula to get what's called the temporal thinning index, the TTI. And the way that we did this to do this study is that we enrolled 32 Alport patients from 24 different families, and we confirmed that all of them had a mutation in the COL4A5. So these were patients that met the criteria for X-linked Alport syndrome. We enrolled both men and women in this, and we did note that this temporal macular thinning was very, very common. And from that, we could then use a normal population to know that the temporal thinning index, the TTI, was in the range of about 4 or 5. In 5% thinning is what we were finding here. There was a little bit of a change with age, so we've got a normal value for what the normal average here, if you were under 41 years old, if you're between 41 and 60, and if you were greater than 60. But we then found with this that we could do statistics, and we would find that one standard deviation away was what we set as a threshold for what we called moderate temporal thinning. And this was in the 6 range. And then we had two standard deviations, which was about an 8% thinning. And what we found, I'd have to go back to to get into the technical nitty-gritty of our paper, but we found that many, many patients, especially males with X-linked Alport syndrome, were very, very commonly well past this severe temporal thinning index range. They would be up at 10%, 12%, even 15%. The women, either carriers or moderately affected, would tend to be in this range. So the importance was we could establish that this is definitely associated with Alport syndrome. We know this is probably related to the collagen mutation, but this is a very, very good screening tool. OCTs take on the order of 30 seconds to do or less. In fact, you don't even have to be dilated to do this. It uses infrared light. It's essentially a painless procedure. So it's a whole lot better than having a kidney biopsy, and can at least give some readily apparent information for under $100. It's probably about $50 is the cost for this type of procedure. And with this, we can at least give some non-invasive insight on diagnosis and prognosis. So even if you are an Alport patient or family member and you're seeing just fine, we do find even other things when your doctor looks at the back of the eye. Sometimes we see fleck retinopathy, so we see little white dots here on the surface of the retina. This is relatively rare in my experience, but I'd say I see it in 25% or so of my patients. And then another thing is what's called the lozenge sign, where there's a very abnormal oval type reflex. A lozenge means diamond shape to British and Australian people. Americans think it's just something for your throat, but you can see this kind of diamond shape here. So these are things that can also help with the diagnosis. So how often do you need to see an ophthalmologist? Well, we do recommend a first exam could be a guide often to whether you need to be seen more often, but we recommend that you see a cornea specialist in case to identify subtle cornea findings. and anything related to the lens, and a retina specialist can help in identifying subtle signs of retinopathy. We recommend, as a take-home point, that you should see an ophthalmologist to help look for signs of Alport syndrome. Should be done at least once as an adult, perhaps as a child. We recommend that it include OCT and wide field color imaging. Most ophthalmologists should have these technologies available, and they are relatively low cost. Of course, tell your doctor immediately about any changes in vision, and be assured that most abnormalities in Alport syndromes are not severe and vision threatening. And the ones that we do see most commonly, which would be cataracts or cornea problems, can be treated with lens replacement. It's very successful and very good outcome. The main thing that I would, macular holes, as I can say though, is in my experience a much more challenging problem, and and fortunately that is not too common. So with that, I think we are to the questions, and I will release my screen, and we will go to questions. Thank you very much.
Thank you very much, Dr. Bernstein, Dr. Alrabadi. We do have quite a few pre-submitted questions. I'm going to get to those. For individuals who are watching this presentation live, please use the Q&A feature and not the chat to submit your questions so that the questions are not missed by myself or Lisa. First question, Dr. Alrabadi, in one of your slides, you noted that teens may show symptoms, but not typically children. With that said, at what age would you recommend beginning a baseline screening? Maybe 13, 15, 18, what would you suggest?
That's a good question. I'll try to do my part, then I will refer Dr. Bernstein. I think what we would agree on is to do initial screening test. I mean, even though we said it's less common in children, I will still prefer to do at least one baseline exam for my children, and then for the children that is, I'm an adult nephrologist, so I don't see a lot of children, but I would, if I have been asked for a recommendation or advice, if I have a child with a family history of Alport syndrome who has a blood in the urine or protein or kidney disease, I would still recommend seeing Dr. Bernstein at least one time, and then based on the finding, we can decide how often or how frequent they would have to see Dr. Bernstein. What would you say, Dr. Bernstein?
Yeah, I think that is reasonable. An eye examination can be done pretty easily on preteens even. It's not something I would recommend in children who are 2, 3 years old, because that would have to be, that's a little more traumatic, and or may even have to be done under anesthesia at too young an age. But preteens and teens, if there's a concern about Alport syndrome, then I would certainly not be opposed to having that done. The procedures, especially photography and OCT, we can do it down to probably age 6 or 7. That's kids do quite well on that. So, but I do want to say, when you go to, if you have Alport syndrome and you go to your local ophthalmologist and say you want to have an eye examination, some of the doctors are going to need to be educated on this. We are taught for our boards to know about lenticonus, but the retina findings are not very well known. And so you just have to remember to say, based on this, and maybe, hopefully the Alport Foundation can help on this, and just kind of say what's recommended, that OCT is important, and probably put a link to our paper. I think that one paper that we cite in my talk today is a very good one, and I think is very accessible to general ophthalmologists.
Excellent. Thank you, Dr. Bernstein, Dr. Alrabadi. We do plan on updating the Alport syndrome website, which is alportsyndrome.org, for those unfamiliar, with a checklist, as you mentioned, to have some of these things to give to your ophthalmologist who may not be familiar with all the eye abnormalities that can occur in our Alport patients. So thank you for noting that. The next question I wanted to ask you is, for an individual who may need a cornea transplant or an eye surgery related to Alport syndrome, how does one go about finding an appropriate surgeon for that type of technique? Is that something that the ophthalmologist would help them then locate?
So yes, I think that there are many cornea specialists and many very good cataract surgeons throughout the United States. Both in private practice and at academic centers. I'll freely say I work at an academic center. I think that for more complex conditions and genetic conditions, I think that many academic centers would be a little more comfortable with that, with seeing patients with unusual conditions as opposed to a general ophthalmologist. So if you have access to an academic center, I think that that could be very worthwhile. And it's the actual surgeries, both for cornea transplants or for cataract surgery, are not especially more difficult in patients with Alport syndrome. So that's good news.
Fantastic. Next question, along the same lines of having intraocular surgeries, regarding an intraocular lens transplant or implant, apologies, are there a time span or a lifespan, if you will, that lens transplant lasts? Is this something that may have to happen multiple times in a patient's lifetime? Any explanation on that would be greatly appreciated.
Sure. Okay, yeah. So for a lens implant, except for pediatric cataract surgery, so you're talking about people who are very young, which would hopefully not be a major portion of the audience here. For adult cataract surgery, for well-done cataract surgery, that is done once in a lifetime. So the surgery itself typically takes 15 minutes, maybe 30 minutes at the most, to take out the cloudy lens and put in a new lens into the eye. When we do cataract surgery, we do special measurements and calculations so that we can get minimal refractive error. So if someone was nearsighted, we can make them so that they don't need such thick glasses. And usually in an adult, that will not change much for the rest of their life. It does not need to be replaced. You do not need a secondary surgery, except for one thing, which is that when we do cataract surgery, we leave behind the posterior capsule of the lens, which is for support. In about 20% to 30% of patients who have cataract surgery, that will eventually cloud up. And that we then have to do a minor laser procedure that takes under 5 minutes to open up that capsule again. That's done as an outpatient. It just has to be done once after cataract surgery. I would suspect in a patient with Alport syndrome, I would suspect that it would be very common that you would need that YAG capsulotomy is what it's caused. But it again is not called, but again, that's not a hard procedure to do, and that's very accessible.
Our next pre-submitted question is actually directed for Dr. Al-Rabadi. Can Dr. Al-Rabadi discuss any issues related to X-linked females and peripheral vision?
So it's peripheral flex, peripheral infiltrate. I did not mean peripheral vision. Those are whitish, yellowish infiltrates, lesions that you can see a little bit farther from the perimacular area where Dr. Bernstein showed the central flex. So it's not peripheral vision. Actually, those, as I mentioned, it's very common even in X-linked females who may only have blood in the urine without any protein in the urine, without any kidney manifestations, may not even have any hearing problem. It's very helpful from a diagnostic standpoint for them specifically and for their male children or female children. So its diagnostic standpoint does not correlate with peripheral vision. Correct, Dr. Bernstein?
That's correct. Yeah, I don't think I've noted many peripheral vision problems in patients with Alport syndrome. We don't routinely do, if we were worried about it, we would do visual field tests called a Goldmann visual field like we would do in retinitis pigmentosa. But they're just a routine screening where we just have people count fingers in various quadrants around their vision. That would be part of the examination, but it's not, we don't need formal visual fields in patients with Alport syndrome.
Next question. Why are cataracts common after transplant?
Are you asking me why?
Right.
Yeah. Right, I'll tell you why. So if you ask who are the patients who have most likely to have cataracts, you will say diabetic patients, for example. One of the reasons, I can at least tell you one of the reasons is that diabetes or de novo diabetes after transplant is very common, related to either the medications, the prednisone, the tacrolimus. All of these medications are very well known to cause or to predispose to either worsen diabetes or to precipitate de novo diabetes. So one of the things I think of is actually diabetes after transplant. I don't know if Dr. Bernstein can think about any other reason for having cataracts after transplant.
I would say the diabetes, but I would say even more so, I would worry about the prednisone. The steroids will induce glaucoma. They will induce cataracts if you take them long enough.
Fantastic. Next question. Have you found any patients with Alport syndrome who have unexplained anterior scleritis?
It's not something that I've commonly seen or heard about. So I wouldn't rule it out being associated with Alport syndrome, but it may also be just a coincidence. So Alport anterior scleritis is typically an inflammatory disease. Alport syndrome, at least is not known to be inflammatory. Do you have anything to add, Dr. Al-Rabadi?
I was going to agree with this. Anterior scleritis, we tend to see it in inflammatory diseases, systemic inflammatory diseases in which you have kidney involvement, but also, I think if I remember correctly, sarcoidosis or things like that can cause some kind of scleritis. So as Dr. Bernstein mentioned, it's more an inflammatory kidney disease. I will say that although Alport is called hereditary nephritis, which was the first name for it, it's more of a structural disease than inflammatory disease.
Fantastic. Our next question from the Q&A. For those with macular holes caused by Alport syndrome, what approach has been most successful for surgically stabilizing and or closing the holes? Is there an option other than vitrectomy?
Okay. So yeah, let me explain a little bit more about macular holes. So macular holes in the common variety that we see that's not associated with Alport syndrome, it has to do with an abnormal interaction of the vitreous with the surface of the retina that causes stretching and opens up a small hole, typically about 300 or 400 microns in size, much less than a millimeter. The way that we treat it is with vitrectomy surgery, removing the vitreous gel and removing those adhesions, and then filling the eye with a gas bubble and asking the patients to spend a few days up to a week face down while the hole heals itself across. For Alport-related holes, I've only operated on a few of them. They are very challenging. I think that due to the collagen problems, the retina is thin and does not behave in our normal way. But if I were to do macular hole on those patients, you would almost certainly require a vitrectomy, and I would probably use even a longer acting gas bubble and ask the patient to be face down even more, because I think the risk of failure is very high. Our normal risk of failure is 5% or less in a normal patient. I would say the risk of failure is more 50-50 in an Alport patient. So I certainly hope it doesn't happen to many of your constituents.
Thank you both. Next question is regarding anything that patients can do to actually prolong or to preserve their native eye health. Are there any vitamins or supplements, etc., that you might recommend for especially our younger patients, maybe those teens and young adults, to help preserve their native eye function? Okay.
So that's always a controversy, especially in younger asymptomatic people. Nutrition is one of my areas of interest, and especially related to age-related macular degeneration, where we know that antioxidants and vitamins, at least in the moderate to later stages of the diseases, are very important. What I recommend to younger patients, where there is no obvious dietary abnormality that would be associated with their eye disease, and that would apply to Alport syndrome, is number one, a healthy diet. Dark green leafy vegetables, orange and yellow fruits and vegetables, and cold water fish are all very important for general eye health. The macula is called the macula lutea, or the yellow spot, because the lutein and zeaxanthin that we consume in our diet is concentrated there. And so I emphasize diet over supplements, especially in younger people. Cold water fish is important for some of the fats. The docosahexaenoic acid and DHA and the EPA that's concentrated in the eye. Again, that's very important. Other things that we say in terms of diet and lifestyle is smoking for many reasons is bad for the eyes. I would, and I'm sure it's bad for the kidneys just as well. So we don't recommend smoking at all. And then excessive light exposure might be a problem. So again, sunglasses are good. In terms of supplements, I don't strongly recommend them because there is nothing that would be evidence-based beyond those dietary recommendations. But for someone who can't or won't eat their fruits and vegetables and won't eat their fish, then supplements could be a reasonable second line choice.
Great, thank you for that. Our next question from the Q&A. What does it mean for me as an Alport patient when my doctor told me he can see, quote unquote, some changes on my retina?
Okay. That's pretty vague. It may mean Alport related if the doctor is very, very tuned in and saying that they see a few of these dots and flecks and maybe even the lozenge sign. Other changes, we use that term, maybe just age-related or something that is not quite normal, but is not too worrisome. So all I can say to the questioner on that is ask questions. What do ask your doctor, what do you mean by these changes? Is this Alport? Is this something else or just something that you need to put in the record? So.
Fantastic.
Yeah.
Next question is actually pre-submitted. What would you tell an Alport patient to motivate them to make sure they are evaluated by an ophthalmologist? Perhaps someone who's maybe content with reading glasses and hasn't seen an eye specialist in years. What would you tell them to motivate them to get some of these great tests that you have both discussed this afternoon?
I can start. So I'll tell them, first of all, I emphasize that for the most part, Alport syndrome may not cause you to have vision changes. And it's mostly helpful from diagnostic standpoint. I also emphasize that it may not be only helpful for you, but may be helpful for other family members or other patients who have Alport syndrome. Sometimes bringing up the possibility, it's kind of our logo. The eye is our window to the kidney or the genetic composition of the body. So I tell my patients, for yourself or for other patients, it's much easier to do this very non-expensive, non-invasive, at most 2-minute test, and Dr. Bernstein mentions even less than 60-second test with no dilatation. It's a very simple additional piece of information that can be helpful for us. What I tell them sometimes is that I did it myself, so to assure them it's a very safe procedure. And I'll tell you, I cannot recall, I have a patient who declined it actually. So for the most part, we have established good rapport with our patients, and once you deal with them medically, I think they trust you on that. So would you add something else, Dr. Bernstein?
No, I think, or not too much more. I think that eye examinations, we can pick, there are many things that we as ophthalmologists pick up that much earlier than the visual symptoms. There are just so many other eye diseases that, like glaucoma, that can sneak up on you and cause all sorts of problems. So having periodic eye examinations as an adult, it doesn't have to be even every year if you're not at particularly high risk. Every 2-3 years is a good idea to have the pressure checked in your eye, see if there are any signs of age-related macular degeneration, other things that that the doctor will see that you and can catch and treat earlier is very important. And I do want to add though, that as Dr. Al-Rabadi mentioned, especially after transplant, there is such a high risk of developing diabetes. Once patients have been diagnosed with diabetes, we definitely recommend eye examinations every year if possible, because the patients, in my experience, the diabetic patients who go blind and develop really bad eye problems, it's because not only have they not taken care of their blood sugars, but they've waited until way, way, way too long And everyone is way behind the curve at that point. And if we can catch diabetic retinopathy early and intervene early, the outcomes are so much better.
Great. Next question was pre-submitted as well. Retinal thinning has been observed in X-linked Alport syndrome patients. Can you explain what happens when the macula gets too thin? Will this simply result in poor quality of vision, or can there be more severe consequences?
So I'd say the main thing is that you may develop some of these macular holes. That would be the #1 problem. I'm thinking about it just right now. We have some newer devices called microperimetry. We may want to, and this is telling Dr. Al-Rabadi, we now have those devices, and we may want to try to correlate that with macular thinning. It's a non-invasive kind of visual field test just of the macula that takes 10 minutes to do, and that might be something that we would want to see, and that can pick up some of the functional problems. But generally, I would say the temporal macular thinning that we're seeing is not visually significant, but is a very interesting and important sign for other reasons.
Is this something you would recommend should still be monitored, perhaps by an annual visit with an ophthalmologist?
Probably that may be too frequent. I don't think at least in my experience, it seems to be very stable. So every couple of years would be fine. I wouldn't obsess over it as the main thing I would say to patients. Do you agree with that?
I look at the same point, Kevin. Dr. Bernstein's study did not show that age makes a big difference in the TTI, the temporal thickness index. However, there has been no study in which you look at the TTI and then you compare it in 5 or 10 years. We would hope to do this, and we're hoping we can do it at one point, but we have not done this yet. To look at the same patients and then look at them in 5 years or 7 or 10 years and see if there is significant thinning.
Yeah.
More changes.
Thank you both. Along the same lines with the macular holes, we've had many patients reach out to us at Alport Syndrome Foundation and note this abnormality. If someone does actually have a macular hole, is there any way that this patient would be able to possibly help ongoing research in the eyes in Alport syndrome? Would you perhaps encourage individuals who do have macular holes to reach out to you gentlemen at the University of Utah to perhaps help future research?
So I'll tell you this, Kevin, absolutely. So at one point we got with Dr. Bernstein and Dr. Gregory being great mentors and collaborators, we got the National Kidney Foundation, and we were funded. Actually, we have several patients who flew from different states, Washington, Seattle, Missouri, different states who come to participate in the study. I would have flown anyone who I have known has macular hole, because we only have 3 of those. Actually, those include one from Australia. So we only have a few of those. So we have definitely been interested in recruiting them, because we want to know more about this. As you know, this is a very studied area in the Alport field, and with the help and the resources of Dr. Bernstein and the resources we have and the support of the families in Utah and the neighboring states, we would have loved to have more of patient recruitment, because only with having more patients we can have clinically and statistically significant studies. Now I have to say, because of our patients and significant interest, and with all the delays in COVID, we ran out of funds and we're not currently able to support the travel. However, to the same point that you and Liz mentioned before, we would love to have the retinal images or any further, any images that was done outside. I already sent you my email. I'll be happy to share it again. And I can streamline the process, and maybe we can still save it as part of our study. And we're in the process of writing the manuscript, and we will be happy to share it with the Alport community once it's published and accepted.
Thank you, Dr. Al-Rabadi, Dr. Bernstein. As we are getting close on time, we have approximately 1 minute left in our presentation. I will be sure to update the Alport Syndrome Foundation website with contact information for our experts here today. So for those with macular holes who have interest in possibly sending off some of their data to these respective experts, we will provide that on our website. We had a few other pre-submitted questions that were really asking about what a typical visit would entail, and maybe the length of time that would entail, maybe post-care. If it's okay with both of you gentlemen, perhaps we'll email those questions to you, and you can help help us formulate a nice one-pager for our community, again, to be put on our website, what to expect during their eye visit, pre-care, post-care, and again, just to highlight some of those more lesser known eye abnormalities that maybe a typical ophthalmologist would not be familiar with when seeing an Alport patient. With that said, on behalf of everyone at ASF and our entire community, I would like to thank both of you for taking an hour of your time to answer our community's questions and for just being so open and receptive to a topic that is largely something that our community may not be familiar with. So again, I really appreciate all you've done to raise awareness Alport-centric eye issues. We're so grateful to have you to help answer our patients' questions and even our fellow physicians' questions. Again, this webinar was recorded. It will be available on our YouTube channel shortly with post-production closed captions. Again, thank you everyone for joining us this afternoon. We hope you stay safe and well. One last thank you to Dr. Paul Bernstein and Dr. Laith Al-Rabadi. I'm sure we'll be in touch. I hope you both stay safe and well. And hopefully we'll see you in person when the time is right.
Thank you
Thank
so
you
much.
both so much, doctors. Take care.
Bye.